Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome everyone! In this episode, we are going to discuss the fallopian tubes, the pair of tubes that extend from the uterus. They are essential for transporting eggs from the ovaries to the uterus and for hosting the process of fertilization. In terms of actual structure, fallopian tubes are a pair of hollow muscular ducts. Each tube is 4 to 5 inches long and 0.2 to 0.6 inches in diameter. Even though they are muscular ducts, they are not thick, pipe-like structures as one may envision. They are actually thin, flexible, soft structures. The inner lining of a fallopian tube is a delicate mucous membrane. This mucous membrane releases secretions or fluids that help nourish and transport eggs, sperm, and embryos. This mucous membrane is also covered in hair-like structures called cilia that also help move eggs, sperm, and embryos through the fallopian tube. Surrounding the mucous membrane is a smooth muscle layer, which contracts to also help move eggs, sperm, and embryos through the fallopian tube. Each fallopian tube can be divided into 4 segments. 1. Infundibulum. This is the far end of the tube, farthest from the uterus, closest to the ovary. It has a funnel-like shape with finger-like structures on the very end called fimbria. These fimbria help to catch an egg when it's released from the ovary, since the fallopian tube is not directly attached to the ovary. 2. Ampulla. This is the middle passageway of the fallopian tube, just next to the infundibulum. Fertilization of an egg takes place in the ampulla if sperm is present. 3. Isthmus. This is a tiny segment of the fallopian tube, just next to the ampulla. It connects the fallopian tube to the uterus. And 4, the intramural part or interstitial part. This is the part of the fallopian tube that connects it to the internal cavity of the uterus, at the fundus. It actually sits within the myometrium or the muscle layer of the uterus. This is where an embryo would enter the uterine cavity from the fallopian tube if fertilization of an egg occurred. The fallopian tubes play an important role in fertilization and early development of an embryo. The 3 key functions of the fallopian tubes are 1. Transporting eggs that are released from the ovary to the uterus. The fimbria pick up the egg released by an ovary and sweep it into the tube. The secretions by the tube, the cilia within the tube, and the muscular contractions of the tube all help to move the egg through the fallopian tube towards the uterus. 2. Site of fertilization of an egg by a sperm. If sperm moved from the uterus into a fallopian tube, one of these sperm may be able to meet and fertilize an egg located in the ampulla region of the tube, and an embryo can then develop. And 3. A passageway to move embryos to the uterus if an egg is fertilized by a sperm within the fallopian tube. Now that we know what happens with normal structure and function of the fallopian tubes, let's understand what can happen if the tubes are not functioning as they should. This is often called tubal disease, or tubal factor infertility, or tubal occlusion, or tubal obstruction. The fallopian tubes may be blocked or damaged due to infection, scarring, or physical obstructions, all of which may prevent sperm from reaching an egg for fertilization, or may prevent an embryo from reaching the uterus for implantation and development of a pregnancy. Some of the most common causes of tubal blockage or damage include 1. Sexually transmitted infections or STIs, such as gonorrhea or chlamydia. These cervical infections actually spread up through the reproductive tract and can cause scarring and damage to the fallopian tubes. When STIs spread through the reproductive tract, it is actually called pelvic inflammatory disease, or PID. 2. Endometriosis. This gynecologic disease involves tissue that is similar to the lining of the uterus, the endometrium, implanting throughout the pelvis, including around the fallopian tubes, causing scar tissue and damage around the tubes. 3. Previous abdominal surgery. Any abdominal surgeries, such as appendectomy, bowel surgery, or cesarean section, may lead to scar tissue around the fallopian tubes. This risk of scarring is increased further if there is any associated infection with that surgery, for example, a ruptured appendix. 4. Physical or mechanical obstructions. Sometimes a uterine fibroid, which is an overgrowth of the muscle layer of the uterus, or a large uterine polyp, which is an overgrowth of the inner lining of the uterus, forms very close to the entrance to the fallopian tube, causing a mechanical obstruction of the tube. 5. Ectopic pregnancy. An ectopic pregnancy is a pregnancy that implants outside of the uterus. The most common site of implantation is in a fallopian tube. Ectopic pregnancies may be treated with surgery, which can include removing the tube, called a salpingectomy, or less commonly, opening the tube and removing the pregnancy tissue, called a salpingostomy. They may also be treated with medication. If a tube is opened up and cleaned out, or if medication is used to treat the ectopic pregnancy, it may still lead to damage and scar tissue within the tube, causing a blocked fallopian tube. 6. Smoking. Smoking has been associated with decreased function of the fallopian tubes, thought to be due to damage to the cilia within the tubes. Blockage or damage to a fallopian tube may occur close to where the tube meets the uterus, or in the middle portion of the tube, or at the end portion of the tube closest to the ovary. If the end of the fallopian tube is blocked or damaged, the tube may fill with fluid, giving what is called a hydrosalpinx. A hydrosalpinx is often asymptomatic, diagnosed incidentally on an ultrasound, but it may sometimes cause symptoms like pelvic pain or even vaginal discharge. A hydrosalpinx has been shown to impact pregnancy rates, decreasing them by as much as 50%. Given this reduction in pregnancy rates, it's usually recommended to remove a hydrosalpinx surgically if found. There are a few tests that can be done to assess the fallopian tubes. 1. Ultrasound. Fallopian tubes are actually not visible on ultrasound. However, a pelvic ultrasound may identify a hydrosalpinx if the fluid-filled tube is large enough to be seen. 2. Hysterosalpingogram, or HSG. This is an X-ray test where a dye is injected into the cervix and the flow of the dye is followed through the uterus and the path of the fallopian tubes to see that the dye fills the tubes and spills out of the tubes nicely. 3. Sonohysterogram, or SHG. This is an ultrasound test where saline or salt water is injected into the cervix and the flow of the water is followed through the uterus and the path of the fallopian tubes to ensure that there is fill into the tubes and spill out from the ends of the tubes. A sono, as it is often called, helps to assess the uterine cavity and tubes. A hysterosalpingogram can do the same, although the dye sometimes fills around lesions within the uterus and does not always identify uterine lesions as well as a sono, so it may be used more to focus on the fallopian tubes than the uterus. 4. Laparoscopy. This is minimally invasive surgery, meaning small instruments and a telescopic camera are inserted into the abdomen. Dye is then injected through the cervix, and the dye should ideally move through the uterus and fallopian tubes and be seen spilling out the fimbriated ends of the tube into the pelvis as long as the tubes are open. Treatment of a blocked or damaged fallopian tube is very limited, unfortunately. Surgery is sometimes helpful. If there is a mechanical obstruction in the uterus blocking the fallopian tube, removal should help relieve the obstruction. If there is very mild scar tissue around the fallopian tube, removing it may help with the obstruction. Although this is not usually the case, it is not common to see a single band or adhesion blocking a tube. More commonly, there is moderate or extensive scar tissue or damage to a tube, and it is not possible to undo the damage surgically in order to reverse the obstruction. Tubal recanalization is a radiologic, non-surgical procedure where a very tiny, thin catheter is threaded through the cervix and uterus and then through the fallopian tube to try and unblock it. X-ray is used to monitor the catheter as it is threaded through the reproductive tract. This is not used very much nowadays, as the tube doesn't always open with this method, and if it does, there is a high recurrence rate of scar tissue and blockage after the procedure. Now I would like to move on to some common questions that I hear about the fallopian tubes. First, I often get asked, can I get pregnant if only one of my fallopian tubes is open? The answer is yes, you can. You can conceive if only one fallopian tube is open. Whether you were born with one fallopian tube, whether one of your fallopian tubes was removed, or whether one of your fallopian tubes is blocked or damaged, it is still possible to conceive with a single fallopian tube, as long as that tube is healthy, you ovulate regularly, and there is healthy sperm present. Another question I hear is, do I have to remove a hydrosalpinx if I am trying to conceive? Hydrosalpinx decrease pregnancy rates by as much as 50%. This is not a small decrease. Some possible mechanisms behind this are that the fluid from the hydrosalpinx is leaking into the uterus and washing out the embryo, or that the fluid in the hydrosalpinx is creating a toxic environment in the uterus and preventing implantation. A hydrosalpinx also increases the risk of an ectopic pregnancy in the fallopian tube. Regardless of the mechanism for decreasing pregnancy rates, removing the hydrosalpinx, or at least interrupting the connection between the hydrosalpinx and the uterus by cutting the tissue where the tube connects with the uterus, will help to optimize pregnancy rates and decrease the risk of an ectopic pregnancy. I'm also sometimes asked about options to treat blocked fallopian tubes naturally. The question that I hear is there anything I can take to help treat and unblock my fallopian tubes naturally? Several natural treatments have been suggested for blocked fallopian tubes because they aim to decrease inflammation in the tubes. Some of the treatments I have heard about are vitamin C, turmeric, ginger, garlic, ginseng, mugwort, and maca. However, I would caution anyone thinking to use any of these. To date, none of these have been proven to unblock the fallopian tubes. Finally, I will often have discussions around both tubes being blocked, from an infection or endometriosis, or even a previous surgery like a tubal ligation. Can I get pregnant if both of my fallopian tubes are blocked? This is an important one to address, so that people know that there are options for conceiving with two blocked or damaged fallopian tubes. In this case, you would need in vitro fertilization, or IVF, to conceive. This is where the ovaries are stimulated to mature a number of eggs. The eggs are then removed from the body and fertilized with sperm to make embryos. And then the embryos are placed, usually one at a time, into the uterus for implantation. Because fertilization is done outside of the body, in the embryology lab, the fallopian tubes, where fertilization normally occurs, are not needed. So there you have it, all about the fallopian tubes. First, the normal structure and function of the fallopian tubes. Second, the causes of blocked fallopian tubes, how to diagnosis, and possible treatment options. And lastly, the impact of blocked or damaged fallopian tubes on your fertility. I hope this episode was useful in allowing you to better understand the fallopian tubes and the significance of the health of your fallopian tubes, meaning their structure and function, on your fertility. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.